Good morning, everyone. Welcome again to a community of practice, changing the way we work. Very excited to have you all here today. My name's Ali Damji, and I'm Division Head of Primary Care at Trillium Health Partners and a family physician at the Credit Valley Family Health Team. And I'm delighted to be your moderator for today. Today's session is going to be focusing on infectious disease updates, as well as opportunities for improving the way we work, with some very familiar panelists who I'm very excited to reintroduce to the group today. I'm going to turn things over to Dr. Eric Wong from the OCFP, who's going to kick us off.
Thank you, Ali. Good morning, everyone. Thank you so much for being here. We've got an hour and a bit worth of excellent content for you today. So saying hello from the OCFP. I'm sitting in for our president, Dr. Jobin Varughese. I'm Eric Wong from London and professor at the Department of Family Medicine at Western University. Just a reminder, this session is certified for 1 credit per hour, and it's been certified up to 32 credits. Back to you, Ali.
In
That's me.
terms of
That's,
the
that's
land
actually
involvement,
me.
go
I'm
ahead.
sorry.
That's okay,
Yeah,
go ahead.
we, we acknowledge that the lands on which we're hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognizes that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respects that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you're calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. Now back to you.
Great, thanks so much. So I'll be taking care of today's reflection today, and it actually comes from a really interesting week where I was one of the faculty that attended our department's Starfield Summit. And at that particular summit, we learned about primary care systems from around the world, and we had delegates that were attending from all different parts of the world, sharing their experiences with primary care and allowing us to learn from one another. And one of the things I learned from that summit was that in addition to what we struggle with in Canada, with 10% of our population not having access to family medicine and primary care, across the world, it's actually as high as 50%. And it made me reflect on just the amount of inequity that exists in terms of access to primary care, not just here, but also worldwide. And when we take a step back and we look at what's going on in our Indigenous communities as well, we know that those inequities are even higher. We know that those challenges are compounded even further. And you can look at it from the context of primary care access. You can look at it from the context of access to mental health services, access to basic needs, whether that's clean water, infrastructure, electricity. And it's something that caused me to pause quite a bit during that summit, as it made me realize just how much work we have to do. On the other hand, as well, too, what I also learned at this summit was how powerful family medicine and primary care are. We saw the evidence worldwide about how primary care also enables us to heal whole communities, to address inequities, to actually advocate to policymakers and others about the challenges that exist in those communities and ultimately improve population health. And so, as we come to today's session, which especially is going to focus on system challenges and opportunities to improve, I challenge all of us here today to have that frame of mind, to think about how, as family physicians, how can we actually think about the perspectives of the communities that we serve and the communities that we perhaps don't serve and don't have access to us? And how do we create a system that ensures that no one's left behind and that we can truly advance that inequity? Because arguably we are the ones who are potentially best suited for that role. So something to think about as we go through today's session. Next slide, please. So, in terms of today's session, I just want to take a brief moment to thank the planning committee for all of their hard work in doing so. And just remember, too, you can access previous sessions online, which I'll remind you about later. Next slide. So one thing I did want to take a moment to remind everyone about is this self-learning option that exists in order for you to obtain main pro credits. So what this option is that you can actually go onto our website, and if you do take the time to watch a recording of a session that you missed, you can actually get credit for watching that session. So in addition to gaining the great CME, you actually can get credit for the fact that you watched that video. But in order to do that, you have to complete a self-learning program that enables you to access a main pro credit for viewing the recorded session. So on our website, if you scroll down, you'll find the self-learning program. Click the link, and there's a 60-second survey that you have to fill out, which will allow you to participate in the program and obtain the credit. Next slide. So this will be the order of today's panelists. I'd like to joke that this is the OG Community of Practice panel because we really have some very familiar speakers who have been here right from the beginning, and looking forward to having Allison kick things off shortly. Next slide. So first, I'm going to turn things over to Allison to introduce herself.
Thanks very much, Ali, and good morning, everyone. Nice to be back. Just to point out, particularly because I'm going to be talking about vaccinations this morning, that I have relationships and research funding from a whole variety of companies that make both vaccines and antivirals. Thanks. Tara?
Amazing. Over to you, Tara.
Hi, everyone. It's so wonderful to be back. I'm Dr. Tara Kiran. I'm a family physician and a scientist at St. Michael's Hospital, and also the Vice Chair for Quality and Innovation at our Department of Family and Community Medicine at U of T. And yes, one of the OG moderator for this community of practice. So it's so wonderful to see all of you and be here with the team again. I've listed here some of my grants and speakers honoraria that I've received, but I don't think any of them pose a conflict for today.
Amazing. Welcome back to both of you. Next slide. Eric?
Yes, so I do receive an honorarium for being here today at this session, and I am employed by Western University and have some honorarium from other organizations listed there. But again, none of those relationships have particular conflicts with today's session.
And as for myself, in terms of conflicts of interest, none that pose any issues for today in terms of funding sources, and I do receive an honoraria from the OCFP for moderating these sessions. Next slide. So in terms of how to participate for today, just a reminder, please use the Q&A function in order to ask your questions, and please upvote any questions that you think are good. So that way those ones will come to the top and I'll see those as the moderator. For the chat, feel free to use that too, but do not use that to ask questions. Please use the Q&A function so that way I can see them. The chat should be used more for networking or your responses to certain aspects of the talk today. Next slide. So again, our order will be starting with Allison. So we'll have her give the infectious disease update, and then we'll break for Q&A, and then we'll move over to Tara to speak more about the different country comparisons and the OurCare. So we'll turn things over to you, Allison.
Thanks very much, Ali. Okay, everybody, this is like 2 minutes on 4 things: COVID, measles, shingles, and pneumococcal disease. If I can figure out how to make the slides move. Okay, so starting with COVID-19, there's 2 things that I watch with COVID-19. The first of them is, and usually I just look at deaths, but pick something on the viral respiratory tool from Public Health Ontario. And from that perspective, things at the moment in Ontario are looking really good. So start with a little celebration. Beginning of May this year is the first year we had an entire week with no deaths from COVID. It's 2020, which is lovely. And then if you look, you'll see that, sorry, there's a bit of a delay on the slides, or I'm not moving. Susan, I might have to get you to move the slides because they no longer seem to be moving for me. Okay, we'll take that. So the second thing to look at is this year compared to last year, there's a 60% reduction in all of the metrics, not just deaths, but all of the metrics due to COVID, really substantially down, looking very nice. Next slide, Susan, please. Whoops. Go back for a minute. Sorry. But the first thing to start worrying a little bit about is, we've talked a lot about seasonality and about thinking COVID comes in the winter, but if you look at the last year, right, it's really not seasonal. So it's important to remember when we're thinking about vaccines and what people need that we still don't know what the seasonality of COVID is going to look like. And it's nice that next year, maybe we're going to have a combined COVID and flu vaccine, but we still don't know if you want the two at the same time. It's also possible, looking at this, really tempting to look at this and say, maybe COVID's over. Maybe we're not going to need vaccines for the whole time. Next slide. But if you look at these are data from Health Infobase now, from the Public Health Agency of Canada, that tracks positive tests, which is the other way to kind of see what's going on. And this is positive tests for Ontario. And you can see that the number is ticking up a little bit. And, beginning of this week, I looked at this and thought, well, that actually looks pretty good. I was really hopeful. And then yesterday, I talked to Ben Cowling by chance, who's one of the big viral respiratory guys in Hong Kong. Next slide. And he said, yeah, we had 6 months of just no COVID at all, and we really thought it was over. But if you look in the bottom corner of this slide, you can see that their severe illnesses and deaths just in the last month have really started to tick up again. So he's betting on it happening to us sometime in the next 2 or 3 months. Next slide. So that leaves us, I think, not being certain about what's going to happen with COVID over the summer, and makes the NACI recommendations look good, which is that adults over the age of 80, congregate living setting for people who are older, and anyone who's moderately or severely immunocompromised should get a dose of COVID vaccine this spring, and anybody who's 65 to 79 can consider getting a dose up to then. And really, I think at the moment, if people want to defer for a few weeks, that's clearly fine, unless they're traveling to Thailand, Singapore, Hong Kong, that section that has really been seeing an increase in COVID cases in the last month or 6 weeks. Next slide. Now, just a note on moderately severely immunocompromised, 2 things. First of all, don't always think about people with chronic kidney disease and the immunocompromised, but NACI has included them. And the second thing is that judging immunocompromised is getting really difficult. And one of the things that NACI is clear about is that it really is a judgment call. So you don't have to fuss too much about whether people are absolutely on any of the different lists that NACI has of what's immunocompromised. You need to be thinking about it from an individual patient perspective. Next slide. Okay, where are we with measles? Well, here's yesterday's measles update from Public Health Ontario. And, you know, the first look is pretty good. That number of cases from May 12th to 18th is going to go up by about 2.5 times when things catch up. And that's still significantly lower than it's been. But we were that low in the last week of March and the second week of April, and maybe things are a bit delayed because of the long weekend. So I think the answer is okay, but not really out of the woods in any way. The other things that I look at when I look at that report is just click down one. The proportion with 2 doses of vaccine is sticking at about 4.1%. That's low and about what you would expect. The proportion of cases in people born before 1970 is 1.7%. That's 28 cases in the whole province. So our rule before 1970, which some of us were a bit nervous about, is looking fine. And the last thing to worry about is whether there's any indication that this is escaping from the under-vaccinated Mennonite, Anabaptist, low German communities, and that's harder to judge from just the report, because people are being really careful to try not to stigmatize communities that really struggled with restrictions during COVID and have issues with dealing with government and vaccines in general. And I have to say, I'm a little bit twitchy because there have been some cases in Ontario this week that don't have sources. So I think the answer with measles is we're holding our own, but it's not getting better fast. And what that means, I think, is that all of us need to be aware for the next period of time that we may be seeing measles cases. Can you just click through, Susan, please? Yep, keep going. Yeah, so all of us should have measles on our mind when we see fever and rash, right? So prodrome before the rash that begins on the face and spread. Next slide. Need to have somewhere in your office what you need to send for measles diagnosis if you see it. Next slide. I need to know where to look for measles exposures in Ontario, which are updated now every day or two. If you see somebody you think might have measles, good place to look. And PHO also has a whole lot of other good advice on their website, including post-exposure prophylaxis for people if you meet up exposed people. Next slide. Okay, shingles, just a note to say that earlier this month, the NACI recommendations for vaccination of immunocompromised folks comes out. That's a marker that we now have really solid data that says, A, that it's safe to vaccinate people who are severely immunocompromised, and B, that the vaccine works, not quite as good in severely immunocompromised folks as it is in other adults, but still clearly a benefit. Don't know what or when Ontario recommendations are going to come out, but if you have people who are going to be immunocompromised and they have insurance or they are able to pay for the vaccine, clear now that they should be getting vaccinated. And then last thing, conjugate pneumococcal vaccine. Let me start by saying I get the fact that pneumococcal vaccine is really boring and we've been talking about it for 40 years and everything's contentious and nobody's that worried about getting pneumonia, honestly. And it's, I think, really hard to focus on in the context of everything else that is going on. But it's also really important for two reasons, okay? The first is that conjugate vaccines for adults save lives in a cost-effective manner. We need to be getting conjugate vaccines into all of the people that NACI recommends them for. But the second thing is that I know there's been a little bit of talk in different sessions about antimicrobial resistance. Antimicrobial resistance is a pandemic. It's a slow-moving pandemic, but that doesn't mean it's not catastrophically bad. And we are in Canada way behind on doing anything about it. We're clearly not going to make the UN General Assembly targets for progress in preventing AMR in Canada. And it's not that that's going to be easy to do, but it's also that every little bit matters. And the truth is that pneumococcus is not only one of the big burden diseases still, despite vaccines, but it's also one of the places where if we prevent it with vaccination, you get the largest reduction in AMR. Because if you get your pneumococcal vaccine and you don't get pneumonia, there's about a 10% reduction in pneumonia from the observational data in the United States. When you give adults PCV 13 and PCV 20 and 21 are going to be better than PCV 13 preventing pneumonia. You get that reduction. That means people aren't taking antibiotics. When you don't take antibiotics, you don't select for antibiotic resistance. So this is a population level intervention that is really important. It's also, I get it, hard. Next slide. It's particularly difficult in Ontario now because we have these really complicated recommendations. So you can do something about it. The first thing to do is to just let these recommendations go, okay? Click down one, Susan, please. Next slide. So the simplified version is to, I'm sympathetic in thinking about people who are immunocompromised and have had vaccines before and need doses. They are more complicated, and I get the fact that we're worried about them. But the population impact here is about the much larger population of people in your practice that are just over 65 or have non-immunocompromising conditions. And for those, the rules are relatively simple, okay? Anybody over 65 with a comorbidity should get a conjugate pneumococcal vaccine as long as it's a year after polysaccharide vaccine. If you're over 65 and healthy, or 5 to 64-year-olds, if you haven't had a dose of pneumococcal polysaccharide vaccine, and we know that most adults in Ontario in those categories have not had a dose of polysaccharide vaccine, then you should be getting a dose of PCV20. So what you want to be able to do, next slide, is to focus on those people. The second thing to remember is that this is guidance from Ontario now. Individuals with incomplete immunization records, that would be like 90% of the adult population of Ontario, right? Or no immunization records should be considered unimmunized and should receive pneumococcal vaccines on schedule. So you don't need, it's good to ask people. 20 years ago, when we asked adults whether they had pneumococcal vaccine in the last decade, many people were uncertain, but if people said they had pneumococcal vaccine, they were right. You could trust their responses. But you don't even have to do it based on history. You should be able to do it based on records and not have to worry about it. So do take the Ontario Ministries of Health permission not to spend a lot of time fussing about trying to find records, but just accept the fact if people don't have records, that you can vaccinate them. Next slide. Okay, so what can you do about it? And it's obviously going to depend on what your practice looks like and who your patients are, but anything that you can do that moves the needle on this bigger group of patients who should get a vaccine that's going to help us make a difference to antimicrobial resistance will help. And while you're doing this, also make sure that if people are being immunized, that they either have a yellow card that they're saving somewhere, or they're using the Can Immunize Act. QR code for Can Immunize is in the bottom. So that a decade from now, when we're talking about revaccinating people with pneumococcal vaccine, which we're almost certainly going to be, we know who's had vaccine. And in my last corner of time, this again is a beg for people. It's going to be really hard to get an immunization registry in Ontario. It's going to require everybody's collaboration to do it. And I get the fact that it feels like putting additional pressure on primary care to do extra things to get a registry. But as we move into adult vaccines, as we start to use them to improve the health of adults, it's going to become critically important that we have a mechanism for recording and documenting vaccines in Canada. So if you get an opportunity to work on what we can do to make sure that happens, please take it. That's it for me. Thanks very much.
Amazing. Thank you so much. And practical as always as well, which we really appreciate. So I'm going to jump right into the questions for you because there's quite a few of them. So the first one here actually I think is was emphasized in your talk, but we'll maybe just restate it, which is, around the large COVID wave that's happening in Asia that's driven by a new variant. And I guess the follow-up question to that is, should we be worried that that variant is going to come to Canada? Is that already happening now?
So, I think the obvious answer is yes. Happened before, going to happen again. It has been really difficult to predict what's happening with COVID in terms of COVID variants, because there's a lot of recombination going on, right? Circumstances where whole segments of DNA move from one strain of COVID to another. So the strain that is currently causing trouble in Southeast Asia is called XDV, and XDV is a recombinant of a recombinant of a recombinant, I kid you not, okay, with a couple of extra mutations. And that level of recombination is making it very difficult for people to predict where COVID is going. So I think opinion is split now on whether XTV is going to spread around the world or whether we're going to keep seeing it's either KP1 or XEC or your list of choices. In some senses, it doesn't matter because there's no evidence that any of these are more virulent or less virulent or more likely to result in long COVID or less likely. So it's kind of whatever happens. It's not impossible that we're going to see something that we saw with Omicron, where XTV is going to move in like 6 or 8 weeks and come really quickly. I think it's more likely that we're going to have a break for a while, but we're going to get into trouble eventually, and I don't know which variant it's going to be when we get there.
Mm-hmm. That's fair. This question's a bit interesting, and I think it actually is nice because it's really fitting with the theme of kind of worldwide issues as well. Is around your comments on antimicrobial resistance, and there was a question here about beyond the pneumococcal vaccine and not prescribing antibiotics unnecessarily for viral illnesses. Do you have any other recommendations for this audience of primary care professionals that we should think about in terms of addressing AMR in our practices?
So I think there are lots of initiatives on ways to reduce antimicrobial prescribing. So if there are opportunities to be part of quality improvement projects or pilot programs or research, I think, and I've not been part of it, so I don't know, but it seems to me that the PHO-led work on, feedback and comparing your antimicrobial prescribing practices to other people's has been effective in getting people to think about it. There's been a couple of other studies recently that have demonstrated that nudges to people that are similar to that. This is in hospitals, okay, with you don't need to use broad spectrum antibiotics here, or you can step down because of the particular circumstances based on electronic records within the hospital have also been successful. So I think encouraging getting into that is really important. It's also true that, almost any of the vaccines that you give are things that are going to result in reduced use of antimicrobial resistance. So I think opinion is somewhat divided about the contribution of vaccines. We have so far in Canada been really focused on getting access to antimicrobials for people with severely drug-resistant infections and on reducing antimicrobial use. But we had the Association of Medical Microbiology and Infectious Diseases had a discussion last week about whether we should be really trying to incorporate the risk of AMR into our decisions about vaccines and developing a plan for what vaccines we were developing and using. And we'll see if that gets off the ground. But I do think, one thing that you can do, okay, is pat yourself on the back every time you get one more vaccine to people, okay, because everything you do counts in this, right? AMR is a wicked problem. There's no simple solutions, no easy things you can do, but every little bit matters, okay? So I think that's the other important faith to have in this, that it feels like you're not doing much, but the truth is all of us doing small pieces is what's going to get us there.
Mm-hmm. Definitely. And then I guess a kind of follow-up from that too is also maybe around the advocacy pieces, like around like agriculture and like animal husbandry, and like how does that play a role, right? Because I imagine there's a large contribution comes from that, right?
Yeah, it's clearly interrelated, but the truth is, for important human pathogens, it's human stuff that matters. So yes, and that's part A. But the other thing is that the farmers and the agricultural industry have actually been doing much better than us human folk in terms of reducing antibiotic use. Now, I think you can argue that maybe they started from a higher level and perhaps it was easier to move. I want to get into this discussion. But I think it's also important for those of us who do human medicine to recognize that even though we don't see it, people in agriculture and farmers have also been working really hard at reducing antimicrobial use. So this is not a one thing or the other. Again, this is all of us in it, and people are the dairy farmers and poultry producers and all of the people who run our agricultural business are also working really hard.
Right, thanks for that. So maybe we'll take things back to humans again. So in terms of one particular question, actually, I keep seeing it in the chat and a lot of discussion back and forth. So I think I'll ask you about this. It's just if you can clarify with Prevnar 13, the other PCV vaccine, in terms of if someone's had a previous dose already of the PCV 13, can you just comment around the PCV 20, just to clarify that for the audience?
Yeah. So at the moment, if you're not in an immunocompromised group and you've had PCV 13, generally you'll have had PCV 13 followed by a polysaccharide vaccine, and you are not eligible for a provincially funded dose. I'm hoping that the next version of these is going to allow people who had doses a long time ago to get doses. And so, in your practice, if you've been an advocate for PCV13 polysaccharide vaccine together, there may not be much of an opportunity to move with a publicly funded program at the moment. But that's not most of us, right? For most patients and most people, anybody who isn't immunocompromised is very unlikely to have had a dose of PCV13. Except I get it in Alan Grill's practice. Okay, I know that.
Thanks. Next question here is around measles. So for measles, adults are often unaware if they've received 1 dose or 2 of the vaccine as children, as you mentioned. For adults born before 1970, they are presumed to be immune. So if there are no records, should adults born between 1970 and the mid-1980s be presumed to have received only 1 dose of the vaccine? And should they be offered an MMR vaccine now, or is the vaccination focused mostly on children?
Clearly children are more important. And if you were in Ontario during that period, we actually did a really good job of getting second measles doses into people of that age. But there is no harm in giving an extra dose of measles vaccine, particularly if it's somebody who travels a lot, is a healthcare worker, has a lot of exposure to children, right? All those things that increase your risk of getting exposed to measles there. If you're born after 1970 and you don't know if you've had 2 doses of measles, it's probably going to come up again, right? Because measles is back with a vengeance. And so there's a good argument for those people when you can't document for just giving them a second dose so that then they can stop worrying.
Great. Next question here is about long COVID. Just curious if you can comment a bit on metformin, the dosing and duration for COVID versus Paxlovid. Is one showing any ability to prevent long COVID, or both together showing evidence? Any thoughts on that?
I think the answer is none of the evidence is good. I think it has been Paxlovid is clearly a very odd drug. It has an impact on mortality, although the impact is not large, and it's really hard to pick patients who are at high enough risk to make it cost effective to use. So I don't think Paxlovid, to me, the evidence that Paxlovid reduces the risk of long COVID in the current state where we are of number of vaccine doses is not good. Metformin, I think there's an argument to use, and I'm sorry, I can't give you doses off the top of my head. I don't know that it works, but it's it's relatively safe and innocuous, and if it's something you want to be using, it's okay, but it's not, is there solid evidence that it reduces the risk? I think the answer to that is no.
Thank you. In terms of the COVID boosters for the fall, I know you talked about this a little bit, or more so for the spring, but this particular question is about COVID boosters in the fall. So will we be giving last year's vaccine, since the FDA seems reluctant to approve new ones, or do you think there will be updated vaccines available?
Sorry, for COVID?
Yeah.
Yeah, there's going to be updated vaccines available. So WHO, the European Medicine Agency, and the FDA have all had their meetings. It's interesting. Again, the evolution of COVID is getting really difficult to predict. And we also have this situation where Novavax, which is the protein vaccine, needs a longer runway than the mRNA vaccines. So the Novavax decision about what goes into the vaccine for the fall had to be made in March and April, whereas the mRNA vaccine companies get to make their decisions in the next sort of month. And as happened last year, there's been evolution in the 3-month period, and people are kind of saying, well, okay, so it's fine to have a JN1 variant in the Novavax vaccine, but maybe we should be moving to one of the variants in the updated vaccine. I think opinion is divided, which probably means that it doesn't matter. We will be getting updated vaccines. The vaccines may not be identical. The antigens in the different companies' vaccines may not be identical this year. but they're all going to be better than last year's vaccine, and new for the fall. Probably again, we won't have them until sometime in October.
That is really interesting. I didn't know that about the like the differences between them in that way. So thanks for sharing that. That's really, really interesting. In terms of the next question here, so if adults are over 18 who are or will be immunocompromised but have had 2 doses of the chickenpox vaccine and never had chickenpox, do they need the shingles vaccine?
Do we think they need, sorry?
The shingles vaccine. If they had the chickenpox vaccine and never had chickenpox themselves, and they had 2 doses, but they are immunocompromised.
Generally the recommendation is that you should be giving shingles vaccine independent of what people's history of chickenpox is when they get to be adults, right? This is an inactivated vaccine, right? So it's not like you can give them an infection with it. And histories of chickenpox, just because you think you haven't had chickenpox doesn't mean you haven't had chickenpox, right? It's vaccine is not 100% protective, and so the general recommendation is, it's a good reason to think about it, but it's not a reason not to vaccinate them. You have somebody who's immunocompromised, who's otherwise eligible, let their history go, give them a dose of vaccine.
Okay, thank you so much. Next question here is, what is the effectiveness of MMR with 2 doses and the duration of immunity from measles? Why are people with 2 doses still getting measles? And should we consider getting a 3rd dose if you're a healthcare worker, high-risk traveler, etc.?
So the correct answer to that is don't know. I mean, the reinfection with measles after 2 doses is sufficiently rare that we do not know whether giving a 3rd dose is going to do anything to prevent further disease. That's number one. Number two, it is clear from what we're seeing now that people who get measles after they've had 2 doses of measles vaccine, even if it was a long time ago, don't get severe disease. Okay, so even if you get breakthrough measles, you get less severe disease.
Mm-hmm.
I think we can expect in the next 18 months, okay, a series of publications from current experience with people. This is the first time, sadly, okay, that we've had any number of cases of measles in people who've had 2 doses of vaccine. We're still only talking about 60 cases, okay? So it's really hard to make conclusions about what's going on when you only have 60 cases to look at in Ontario. The Americans have more, okay? So I think we'll start to see things, but at the moment, it's still rare. Goal is to get our measles elimination status back, right? It's generally not severe disease, and the number of cases is still really small. So I think the answer is we'll wait and see. But we don't have evidence at the moment that, you don't know whether people who get measles after they've had 2 doses of vaccine get measles because they just don't respond as well to the vaccine as other people, or whether it's a timing thing and you can actually get a benefit from 3rd dose, right? We need the answer to that question before we start talking about 3rd doses.
Great. Thanks so much. So I think with that, what I'm going to do is I'm going to move things along to Tara's presentation, but we will circle back to some more infectious disease questions as well for today's session. So thank you so much, Allison. I'm going to pull up these slides as I have one last thing I want to share before we turn things over to Tara, which is just that Public Health Ontario is running a survey right now, the Infant and High-Risk Children RSV Prevention Program. So this is specifically around the Beyfortus rollout. So for those who provided the product, it's technically not an immunization, but the monoclonal antibody. If you provided that to your patients, there is a 10-minute survey that's going to be focused on this particular upcoming season. The deadline for the survey is May 31st, and we will circulate the link as well. So with that, I'm very happy to turn things over to Dr. Tara Kiran.
Thanks so much, Ali. It's so wonderful to be here. And yeah, we're going to be shifting gears from what Allison has been talking about and may actually also have some great discussion that might be in contrast to some of the things that Allison was encouraging us to do in our practices. So yeah, it'd be really interesting. I look forward to this discussion. So I should say, as you know, I'm a family doctor and a scientist. I don't work for Ontario Health. I also don't work for the Ministry of Health. I think I'm just putting that out there because I know some of you may have questions about what the ministry is going to do, et cetera. And I can answer from, my view outside of that space, but I can't answer on behalf of them and don't necessarily have insight to all their thinking. So I'm basically presenting today, on some research that we've done over the last 3 years, and then also, my goal today is to try and just spark a conversation among all of us about the current state of primary care in Ontario, where it is that we need to go, and how it is that we might be able to get there. Understanding that a lot of it is, of course, beyond our own agency, but that probably some of it does have, relate to things that we may need to do differently if we really want to have a different system. And, are we interested in doing some of these things differently? What are we not, interested in doing? So that's my intention with today's presentation. I'm going to start off by telling you some about the work of OurCare. So OurCare, as many of you would know, is an initiative we did that was launched back in 2022. Basically, over 16 months, we heard from nearly 10,000 people across the country, patients and the public, about what it is that not just their experiences in primary care, but what they wanted to see in a better system. Why did we do this work? I mean, I will say that as a family doctor and a researcher, I often reflected over, the 15 years that I've been working as a researcher, that often when we talk about primary care reforms, we'd have certain people at the table. We would have physician representatives, other clinician groups, health organizations, obviously people from government, researchers, but the voice of the very people that the system is supposed to be designed around, patients and the public, was missing. And that was really the impetus behind OurCare. And so we did OurCare in 3 phases. Each phase was designed to do something different. So the first phase was our national survey over basically in the fall of 2022. We conducted a survey over 6 weeks where we heard from more than 9,000 people about their experiences of care, but also kind of, their opinions about, what if we did things differently? Would you be okay with that? And also their values. But really, the most, I think, critical part of OurCare were the dialogues that we had with patients and the public in our next 2 phases. So in the 5 provincial priority panels, I should say, basically, these were citizen reference panels that occurred in one of each of the 5 provinces across the country. And so this is a photo, actually, of our group in Ontario. These were all strangers that we brought together. And basically they spent 40 hours with us learning about primary care and then deliberating about what a better system might look like. It was really beautiful to watch. And we did this not just in Ontario, but in Manitoba and Nova Scotia, in BC and in Quebec. And what was remarkable is that each time at the end of the sessions, they're able to come to a lot of consensus. And as we'll talk about when we look across the sessions, actually, there was a lot of common themes. And then I mentioned the round table, the 3rd phase. The 3rd phase were actually our community roundtables, and these were basically one-day sessions where we in conjunction with community organizations to really hear the voices of marginalized communities. And so I'm not going to go into a lot of details about all of this. I can speak for a long time about our methods and what we found. But I did want to share the outcome of what it is that we did. And maybe what I'll also do is I see that Pavitra has already put it on the chat. You can obviously go to our website if you want to read any of our 17 reports that we put out there. But our final report is, of course, the most important, and it summarizes what we heard from all of our engagements. And we introduce a concept called the OurCare Standard, what it is that every person should be able to expect from the primary care system. And the OurCare Standard is really a distillation of everything we heard across these engagements. And as I mentioned, it was really powerful to hear how it was that people really agreed on so much. And the thing they agreed on at the most fundamental level was that everybody in Canada should have access to primary care, and it should be regardless of their background or their geography. And so I'm not going to, because of the time involved, again, I'll maybe just skim through what the standards kind of talk about, but there is more detail in our reports. But just to say that the first standard is really laying out that everybody should have a clinician who works with other health professionals in a publicly funded team. Why team? I mean, I think people understood that if we really want to address the access crisis, that's going to require clinicians working in teams. And they wanted, the comprehensive care that goes in a team setting, and understood teams also could address burnout. They wanted care that was timely and ongoing. By timely, that included, after hours and weekend care, and care that was where virtual care was integrated with in-person care. Particularly, they talked about virtual care as a way of bridging access issues in rural and remote communities. The third standard really talks about this idea of a wellness-oriented system instead of a sickness-oriented system. And for that, they wanted to see primary care connected with community and social services to support overall well-being. We heard a lot of frustrations about people not being able to access their own record, and so Standard 4 really addresses that point. Standard 5 has a lot in it. It's that everyone should receive culturally safe care that meets their needs from clinicians that represent the diversity of the communities they served. And this really relates to instances of racism and discrimination that we heard in many of our engagements. Ultimately, we talked to people. We also heard that even though some people had access to care, there were still barriers. And so when it says meet their needs, I mean, they wanted primary care to meet the full needs. So sometimes they would talk about going to primary care, and, let's say they had a mental health or addiction, and the primary care clinic might be like, no, that's not within our scope. We can't help you. So, the clinic should be able to help with their full needs. They should be accessible from a language and a disability barrier perspective. And when the people in the workforce look like the people they serve and are from those same backgrounds, we heard that makes the care much more culturally safe. And the last one is about accountability. So this means transparency in the system. This means that the system is accountable to communities. So this means transparency. This means that patients and public are involved in decision making about services, about what measures we use to take a look at how primary care is performing. And it also means that we help to empower and educate patients and the public. So that's sort of a high-level overview. And what was, of course, really amazing to see was that the OurCare Standard now is the basis for legislation that was introduced into or an act that was introduced into the legislature on May 7th. It's a first of its kind, the Ontario's Primary Care Act. I know many of you have probably heard about it, but some of you might not have. Because it hasn't gotten any media attention yet. It's just been introduced, and hopefully will be passed in the coming weeks. Hard to imagine that any opposition party would be against it. But what you can see here is that, the act, if you read it, it's short. It basically says that primary care is the foundation of the system. And then it says that the primary care has these 6 objectives. And as you can see, the 6 objectives align with the OurCare Standard. They're actually not presented in this order, but I have move them into this order so you can see the alignment. So this has been an incredible win for the people of Ontario, I think, and all of us, to have a health system objectives that are based on what patients and the public say that they want, I think is incredible. So I think we all should feel good about, and optimistic about where it is we're heading in Ontario. I think we are leading the way in the country. We didn't talk about this, but when you look at the OurCare data, as bad as things are and feel in Ontario, they're actually a lot less bad than they are in other places in the country. And I'm hoping this will actually take us further. But of course, the reality in Ontario, as I mentioned, it is far from this where these objectives point us to. And so the objectives lay out a North Star, but what we have in Ontario right now, of course, is the situation that I think where we have haves and have-nots. And in fact, I would say we have have pluses. So we have people who have family doctors working in teams, and they have access to all this wraparound care, and it's amazing. And then they may have family doctor working with a medical office assistant, still getting really, really good care, but they may not have the benefit of a social worker or pharmacist. But then we have people who have absolutely no care, and it's heartbreaking to hear from those people. I'm sure many of you have encountered them, and they're struggling every day not to be able to get care for their chronic conditions or acute conditions. And so I think this, leads me to the next part of my presentation where, I wanted to just put forward some ideas about how is it that we can think about doing things differently to try and get to that vision of the OurCare Standard. And what I want to actually reflect on actually is some learnings that I had through my travel. So was really fortunate over the last year to actually be on an academic leave. I had someone covering my clinical practice, and it allowed me some more flexibility to, do some stuff related to OurCare, that wrapping it up, but also travel to a few countries where they do have really high performing primary care. So I went to Denmark, Netherlands, and Spain. And in Spain, I should mention, it's a decentralized model like ours. So I was in the province of Catalonia. But in all these countries, 95% to 100% of people have access to primary care. And some of my interest in this really stems from a paper we wrote back in 2023 that looked at comparator countries that do have almost everybody in their population having primary care, and this idea that can we learn from them. And as I share with you some of my observations from these countries, I do want to put it in context that these countries are different from us in important ways. Importantly, they actually have a lot more doctors per capita. They have a higher proportion of spending that's public generally, higher taxes to GDP ratio, more social equality. They actually aren't plagued by the opioid crisis in the way that Canada and the US has been. Definitely less ethnic diversity and also smaller geography. So I just conscious of, that there are contextual differences, but I still think there is a lot that we can learn. So to start, actually, I think what was interesting in all three countries is what they don't do in the primary care clinical office. In all three countries, I observed that primary care clinics are not responsible for colorectal cancer screening or breast cancer screening. These things happen for the population, but they're actually organized by a national agency. Cervical cancer screening, so Pap tests, are still done in some of the clinics, but in places like Catalonia, they do a lot of HPV self-sampling, so the need for clinic-based Pap tests is a lot less. Places like the Netherlands, they've trained someone, not even a nurse, but someone called a practice assistant who actually is able to do Pap tests. So it's not a doctor, it's not even a nurse, but another trained health workforce member who's doing them. So taking work away from physicians and nurses. Interestingly, and this is kind of ironic on the heels of what Allison just talked about, but actually they don't do preventive care visits. I did not observe that in these countries. When I talked to some of the doctors about it, they were like, yeah, don't think that's a good use of our time. And generally, it's not to say that this is not important. Of course it is. But a lot of these functions are taken up by other places. So in the Netherlands, immunizations and well babies are actually done in different clinics, not in the primary care center. They just do the flu and maybe pneumonia shots in the clinics. They don't have well adult checks. So very different approach. And I think this is an interesting debate that has actually arisen in the British Medical Journal. So a really interesting article there that you can peruse. And that's caused a lot of discussion. But I think it harkens back to this thing of like the opportunity cost of related to what it is that we choose to do or don't do. And so what is it that people do, family doctors do in these countries if they're not doing these things? They're spending, in my observation, a lot more time doing acute care and complex chronic condition management and complex mental health, psychosocial issues related to chronic conditions and other issues. Interestingly, they do have some accountability for access. In Denmark, it was really interesting to see, in their contract, if you have this is actually a clinic that I visited there, but, they have a contract with the region, if they have a license to open their practice, and the contract really just specifies like 5 things, like for a full-time practitioner, you have to roster 1,600 patients, and you have to be open Monday to Friday, 8 to 4, participate in after hours, see urgent issues the same day, and non-urgent issues within 5 business days. And they've structured their clinics to be able to deliver on this. It doesn't mean that the doctor themselves who has that license for the practice, the GP owner, is necessarily working Monday to Friday, but actually, they could hire a locum to be there 2 days a week. But the practice owner is responsible for ensuring that the practice is open in these times. So it was striking to kind of see these accountabilities that were there around access. And in particular, it's important to note in Netherlands and Denmark, you actually have to see your GP before you can actually go to the emerge. So they really have to be very available. And one of the things that I saw done really well, particularly in the Netherlands, but also in Spain and other countries, is this concept of demand management. So how do we ensure that if we're looking after a large roster of patients, and in the Netherlands, their average roster is like 2,300, how can we ensure that the right people are getting care from the right person at the right time? What can wait till next week? What has to be seen today? What can be seen by the nurse or the doctor? And in the Netherlands, there's this wonderful role of the practice assistant, a person who actually was trained for 3 years out of high school, specifically in primary care triage and communication. They staff the phones, but they do a lot more than that. They also do simple procedures. They're really thought about as the right hand of the GP there. And if you're interested in learning more about this role, I'll tell you later that I've started my own podcast, and actually the most recent episode features this practice assistant, Chris Arts, who I met there, and I interview her, and you'll learn more about her role. But it's this idea of demand management of like, how do we ensure that we see the sickest people today and that the others can wait, or that others can be seen by our other team members? It is something that we struggle with, I think, in primary care here in Canada, because many people report consistently it's really hard to get an appointment when they need to. It is so, in all of the countries, I observed a lot of delegation, so delegation to folks like practice assistants, but then the standard role in all 3 countries was doctors working very closely with nurses. And the nurses really functioned very independently. So for example, if you had a patient with diabetes, the diabetes patient may see the physician only once a year, and the other 3 visits in that year would be done independently by the nurse, who would consult the doctor if there were any issues. But stable chronic conditions, diabetes, asthma, hypertension, cardiovascular disease, COPD, those were really taken care of by the nurse. And I observed the difference between some of our settings where often there's sort of some duplicative care where the nurse and the doctor might see a patient on the same time, and that doesn't actually free up doctor time. It maybe reduces the amount of time in that visit, but doesn't free it up in the same way as the nurse really taking the whole thing over. So those are some of the practice specific things. And as I said, it made me wonder, what can we do? What would happen if we actually shifted some of our time from preventive care to doing more complex chronic conditions and acute care. And why do I say this? I mean, it's not that preventive care is not important. I do want to emphasize, I do think it's important, but we have millions of people who literally have no place to go for their chronic condition care or their acute care. And in that context, I think we have to rethink kind of where it is that we are spending our time. So I just want to quickly throw out a few other ideas that are kind of more system level, but do still touch practices. And so the first is this concept of integrated after hours care. Really interesting in the Dutch system. They're responsible for their patients 24/7. That used to mean every doctor was on call on their own. But now they've actually, over the last 20 years, banded together in GP cooperatives. So these are organizations owned and run by GPs who actually provide this really standard, high quality, organized after hours care in every region. So it's hundreds of GPs working together to cover hundreds of thousands of people in a region. A lot of it is based on virtual triage. So you've got your practice assistants staffing the phones, one GP supervising 10 practice assistants often at one time. And they're working on really detailed algorithms. And then, if somebody needs to be seen, there's a GP on site, a different one who would see them in person. And there is also a car and driver that could take the GP to the home if someone's actually not able to come in person. And these are often adjacent to the emerge, but they are different than the emerge. So really interesting concept that we'll be featuring actually on our next podcast episode. I did also observe, that there was more empowerment of patients to self-manage chronic conditions. So here, if someone has conjunctivitis, a condition that actually requires usually no treatment, they can go to a pharmacist, even though they don't need to, and they could probably be managed on their own. But in the Netherlands, they have an amazing site that actually was created by the Dutch College of GPs. Though that college creates guidelines for GPs by GPs, and they hired a communications firm to actually translate some of their guidelines for the most common minor ailments for patients to be able to go on their website and be able to see how can I self-manage these things at home. And I'm told it's actually the most popular health website in the Netherlands and has reduced actually demand in primary care offices for minor things that people can manage at home. They do have, somewhat integrated records, but more than that, actually an integrated digital viewer. So in Catalonia, a country in Spain that has much fewer resources than we do, since 2009, patients have been able to access their immunizations, their medications, their lab tests, all of that on an app. They've been book appointments on their app with their primary care doctor, and they can also message with primary care on their app. So a long way that we need to go. And this, I think all these system pieces would actually make our lives a lot easier as well. The last thing I'll say is that they were really, in Spain, I was struck by how centered they were on patients and communities. So their centers are very much like a school model. Anybody living in the area can get care at that center. And they actually engaged communities, both from a quantitative perspective. So they had worked with an epidemiologist to understand changes in population demographics, but they actually did qualitative focus groups with folks to understand what is it that they were needing help with, what were the health issues most top of mind, what the services that they might want, and try to design their care around those needs. So if you're interested in learning more about these ideas, you can go to my podcast. We're talking lots about this kind of ideas and how it is that we can achieve the OurCare Standard. We'll also talk about innovations in Canada, so not just around the world. So if you put in Primary Focus or Tara Kiran into any of your favorite apps, you should be able to find it. I wanted to mention too that we would love your support in being able to send out the OurCare survey. We've just launched a new one, OurCare Survey 2025, to understand people's experiences of care and how it matches up to the OurCare Standard. But we'd love your help in sending it out to your patients, to public members, to community groups. And so you can just go onto our website, ourcare.ca/survey. I see there's lots of great chatter. I look forward to looking at it, and I will turn it back to you, Ali.
All right, great. Thank you so much for that, Tara. And yeah, there's definitely been some great discussion elements here. Maybe before we go to your Q&A, Actually, let me just see what's going on with the slides here. Can we just quickly, I might just turn things over to Eric quickly to just introduce these quick workshops, and then we'll turn things to you.
I thank Ali. So just as a reminder, besides this amazing session that we have, we also have some other offerings through the OCFP. One that's coming up June 6th, the osteoporosis and fracture prevention workshop. If you haven't been to one, is an excellent one to go to. Next slide. And also as a reminder, we do have another community practice, and we do have sessions focused around mental health, addictions, and chronic pain. Additionally, we also have a Peer Connect mentorship program, which provides one-on-ones or small group support for family physicians looking to learn additional tips and tricks around mental health, addictions, and chronic pain. And all of these are available on our websites. Back to you,
Perfect. We can take down the slide deck. I'll do that last couple slides at the very end. So we'll jump right into some questions for Tara. I think the first one that came up a few times in the chat as well is just if you can comment on these particular systems and whether there is a parallel private system that exists in them as well, or if they are a single payer public model like ours in Canada.
Yeah, it's a really good question. So it does depend on the country, but I'll start, I guess, with Denmark and the Netherlands. So there isn't really a private system that's in parallel. Everybody goes to the publicly funded GP. They spend a lot more in their public system, as I mentioned, all three countries or actually the Netherlands and Denmark in particular. I think Spain spends about the same maybe as us, but the Netherlands and Denmark, they spend a lot more in their public system than we do. There may technically be an option to be able to pay privately for something, but I don't think actually anybody does that. It's like far less than 1%. Even, rich people are not going to go to a private, and then you don't see them. In Spain, it's more complicated. There is a private parallel system, but the private parallel system is actually mostly to access specialty care. So again, I actually had the opportunity while I was there to meet with the CEO, for example, of Teladoc, and he was like, he uses the public system. People use the public primary care because it's considered to be really good and accessible. But it is actually complicated because civil servants have a different kind of insurance and they can access care through their insurance in a different way, but then they have to opt out of the public system. So it is complicated, and I don't think I can explain it in the 10 minutes here, but just to say that most people, the vast majority, are receiving care in the public system in Spain as well, but that is the one that does have parallel private, and my understanding is it's mostly to access specialty care.
Thanks. Yeah, go ahead. Sorry.
I guess, I think I was just looking at some of the chat, and I will just say that, I think it's true that there are cultural differences in how people access care and the expectations people have. So we want to just put that out there. I think that is an important contextual difference. But I do think that we can still support education and empowerment of our own patients and community members to be able, people want to know more about how to navigate the system and look after themselves. We heard that over and over. People were actually super grateful for the education they received during the OurCare sessions, and they really wanted everyone to receive that kind of education. So anyway, I wanted to acknowledge that. I also wanted to acknowledge, I think some people were talking just about how if we just did chronic conditions, it would be less attractive to medical students. But I also have to think about when we think about team-based care, I think working to the top of our scope, we really go to school for so long and have so much advanced training. To me, it's how can we use that training to really from a healthcare perspective to optimize the care delivery to our community. We are a resource to our community as well. So I recognize that some people, but when I talk to the Dutch doctors, are you okay that you don't do well babies? They're like, oh, well, we still see kids. They come in when they're not well or if there's a problem. So I did ask about that, and that was the kind of response I got. Sorry, go ahead, Ali.
Interesting. Yeah, no, thanks for sharing that. So another question here is just around the remuneration models. Are they in a fee for service type style? Is it a salary type system? How does that work?
Yeah, So the Dutch and the Netherlands and Denmark are actually GP owner models. So it's very similar to ours in the sense that GPs are practice owners and self-employed. There is more accountability in their contracts, but they are self-employed and run, and so they pay for and hire the staff. So, and for the most part, their teams consist of nurses, and in the Netherlands, it's this practice assistant, which I would say is more highly trained than the average office assistant. And in Denmark, it would be an office assistant. Spain, it is a very different model. So there it's, public infrastructure, like very much kind of like a public school model. Like you've got a health center in a community. It's public, the infrastructure is public. All of the health professionals are employed. The doctors work certain hours per week, as are other people there. And so and there is some separation, I guess, of who in the government does the planning versus the delivery versus the purchasing versus the delivery of the services. But there is some, I think, private company delivery of the service, but most of the centers are actually run by a public agency in Catalonia. And as I mentioned, I went to Catalonia, so that's not all of Spain,
Right.
and other regions may be different.
Great, thanks.
And I
Another
should actually, just
Yeah,
another interesting
yeah, of
tidbit, I
course.
will
Yeah.
say that in Denmark, it was really interesting to see how well respected family doctors are. Primary care deals with 90% of health system contacts there, which is really amazing. And then GP owners actually on average make more than specialist counterparts. They have actually fairly similar training lengths. So, maybe 5.5 years versus 6 years. So really, and they did note some of the leaders there who I spoke with that, they think that when they increase the residency length for GPs in Denmark, that actually following that the incomes did rise. So just sharing what I learned from folks there.
Very interesting. Food for thought for sure. Okay, another question here is around, I guess, like the funding elements here. So, like, I guess this, and feel free if you don't want to comment on this, but I'm just curious about this because with the advent of, team-based models and with some of the OurCare standards around that as well, certainly that's going to cost a lot of money. It's going to require a lot of resources, IHPs, additional physician resources, etc. And I'm just curious if, in your experience, like with our care or also with learning from these other countries, if there is sort of like any ideas around how we're going to actually accomplish that, right? Because it's one thing to put it, I guess, into a legislation, but then in terms of actually getting these resources or, developing the funding for these plans, I don't know if you've heard anything or if there is anything you can comment on with that.
Yeah, sorry, and I'm also got distracted by the chat. So just to say that, yes, the government here has committed more money, we do need to invest more. I'm when you look across there's a few different important contextual factors when you compare Canada to other countries. So one, as I mentioned, is the amount of money we spend. We spend less in public health care than all of the countries, the 9 OECD countries that we looked at in our paper from 2023 that I can put in the chat that was published in CMAJ, that we spend less on public health care than all of those 9 countries that have higher performing primary care. So that's important. We have less overall doctors per capita. So that also means that it's harder for us to access specialty care. It means that we also have fewer doctors who can be family doctors. And even if we look at the total the whole health budget we do have, the proportion spent on primary care is less. So there's no question to me that we need to spend more on primary care. That is part of the issue. We have to, of course, though, spend it wisely. I mean, there are things that people are frustrated about, understandably, like for 20 years, we were supposed to have more integrated records and it's not gone anywhere. So, that's a frustration where, yes, money is part of the issue, but it's clearly not all the issue. And yes, I think so. People are talking about teams and they're wondering, did people want just, what's going to happen with individual continuity? I mean, people ideally do want to have a relationship with a family doctor or nurse practitioner that's ongoing, who knows them. we heard that very loud and clear. I will also put forward that people do want care, just period. Like that was very clear, right? Like, so they're willing to compromise on some things if they can get care because like the situation is so awful out there. I think Alan asked an interesting question, like, so around like, so I talked about teams and what our role is and how I think we should work at the top of scope. And he's like, who decides what the top of our scope? But I don't think you need to go to school for 9 years to counsel someone on cervical cancer screening and do a pap test. Other people may disagree, but I don't think that's the case. I think there's a lot that we have learned over our schooling that is really like allows us to deal with such really challenging problems. And I think that is ideally where we spend our time. But again, others may disagree. So but I will also say that's my observation from other countries. And so what I was doing today was also just sharing what I was learning.
Yeah. And yeah, that's really, really helpful for us to hear these reflections, and like we really appreciate you sharing these insights as well. Um,
Mhm.
I guess maybe one final question I have for you is just a bit of a reflection. So, I guess currently with the Ontario approach and like where things are going with the Primary Care Act and with some of these developments that you mentioned today, like how well does this align with, I guess, what you're also seeing from the OurCare Standard, from your line of sight as an academic and a scientist? Are we kind of moving in the right direction, would you say? Or, are there still elements that you think are really fundamentally missing that we need to address?
I feel like in Ontario, we are moving in the right direction. I feel a lot of us feel very hopeful and excited that Jane Philpott is at the helm of the primary care action table. Jane is obviously actively, has practiced as a family physician for so long and has deep government expertise and educational expertise, so many different lenses that she brings that are really important. And yeah, I think a lot of us just feel confident that she'll, if somebody's able to do it, it will be her. Um, I will say, I think actually I feel so much more hopeful and confident in the province of Ontario than elsewhere. I think we do have a really great foundation in Ontario with some of the teams that we have built over the years. I will also just take this moment to just also, I can't help but skim through some of these chat comments. I can't get them all. But just there's been an interesting, discussion here, like, okay, well, if we're just doing chronic condition management, why don't we just like do an internal medicine residency and get paid more? I mean, I think we need to get paid more. Let's just like put that on the table. I love that Danish doctors get paid, family doctors get paid more on average than specialists. I think one of the things just to emphasize again is that they're not just doing more complex chronic conditions, but they're doing a lot of like seeing people who have new problems, like, I have pelvic pain, I menstrual bleeding, I have like a sore back. Like they are making available their time for more acute conditions, and I think that is appropriate. So yeah, I do feel very hopeful about where it is that we are going, partly because we have, I think also in principle understood here that primary care is the foundation of the healthcare system. That act says that, and I think that's a really major step forward. And I think that it's patient and public oriented is also wonderful. I do think there is some stuff that I hope that can be done more quickly than others. Um, I should say around, this was a very short presentation I gave Ali. I could give a presentation on each of these health systems for
Yeah.
an hour and go way more in depth. And so I hope that I haven't miscommunicated kind of what things are happening. When I talk about things like the Dutch College of GPs, I see some come. It's very different than the Ontario College of Family Physicians. The Dutch College of GPs, their raison d'etre is actually to produce guidelines for GPs by GPs. That's not the raison d'etre for our colleges across the country. And so what I also see in some of these other countries is doctors actually banding together to self-organize to support themselves more and somehow managing to, I guess, get the infrastructure to be able to do that kind of thing. So yeah.
Okay, well, thanks so much for that, Tara. Those are really helpful reflections and observations there as well. I know initially I was hoping that we would have some time too for infectious disease, but I think we are getting towards the end of time. Maybe what I might do is I might just read a few of the answers that Allison has put into the Q&A. And Allison, if you want to comment as well too on any kind of major themes that came up as well that you were answering via text, I think that would be good. So maybe I'll turn things to you first if there's anything you wanted to highlight specifically that we didn't get to initially, but that maybe you answered since.
There's a couple of questions about measles doses given early to 6 to 12 months. The reason we don't do it is not because giving it early poses a risk later on. The reason we don't do it is for measles, antibodies from mom stay around much longer than for other diseases. So if you vaccinate kids before they're 12 months of age, they may still have measles antibodies from mom, which is good because it protects them, okay? But it interferes with the child's primary response. So you have to give measles doses after 12 months to get good long-lasting protection. What that means is you can give measles doses at 6 to 12 months as long as you give 2 measles doses later. There's no harm associated with it. It's the only harm that happens is if they only get 1 dose later, then they don't get as good protection in the long term. And I think it's important to remember that we still haven't seen an outbreak case in Toronto. There's 2.4 million of us in Toronto, right? So in some areas of the province, the risk is still really low. In areas of southwestern Ontario, it's different. And so you, I think, have to judge whether those children should be getting vaccine. I think there's also a bunch of concern among patients, and I think there's absolutely nothing wrong with giving an extra dose of measles vaccine if you have parents who are really concerned about having their child best protected.
Okay, thank you. Yeah, I think that covers kind of the other elements that were answered there. So thanks so much for that, Allison. One other quick question I was going to ask you, just because it was a popular one that we didn't get to, was do you think that Shingrix should be given to average risk people at age 50, like the product monograph says, or should we wait till 65? There is also, I think, some new studies coming out about prevention of heart disease after shingles vaccination. I think there was one about dementia as well too. Are these true? Should we be thinking about this? Should we be vaccinating everyone earlier? What do you think?
Okay. So, it's really a cost effectiveness question, I think, and I remain unconvinced that for healthy adults, a dose of Shingrix at 50 is cost effective at the usual, cost effectiveness numbers that we think about in Canada. So it's absolutely fine to get Shingrix at 50. It's really a question of whether we should be spending money on it within the public health system. So I think that's why opinion is divided about what the right thing to do with that is. And I'm sorry, I've lost the second piece of that
just
question.
around the heart disease and dementia
the heart
prevention.
disease. Okay.
Yeah.
So I think opinion is divided. Okay. You will remember that there are also studies that demonstrate that flu vaccine prevents dementia and that flu vaccine prevents COVID infection, and that high dose flu vaccine actually prevents all-cause mortality in Denmark. The challenge with all of these studies, observational studies, is that people who get their flu vaccine and who get Shingrix are also people who wear their seatbelts, see their family doctor for preventive visits, wash their hands. There's a prevention mindset that we have no measure of. Okay. So yeah, if you get your flu vaccine, you're less likely to get COVID. That's not because flu vaccine protects you from COVID. It's because if you get your flu vaccine, you're more likely to get COVID vaccine. So my belief is that yes, you are less likely to have dementia if you get Shingrix, but it's not the Shingrix doing it. It's the fact that you get Shingrix means that you eat better and you exercise more and you do all of those things that reduce your risk of dementia. And so there's an association, but it's not causal. But that is an opinion as opposed to sure, safe evidence. And it's going to be really hard to get the evidence because we're not doing randomized control trials, right? So you can believe what you wish.
Fair enough. Well, thank you so much to both of you. That was such an engaging session, and also a huge thanks to all of our attendees because you really made the session amazing by contributing so many insights and actively participating in the chat and the Q&A. And I think there's some really great insights that we can take back. I think all of us individually to our own practices and our own thoughts around how we can improve the system, but also I think for the OCFP, for the Department of Family and Community Medicine at U of T, a lot of us engage in health system advocacy work that are members of this community of practice today. And I think all of us can take a lot of insights from today's sessions and inputs from everyone today. So thank you so much for that. I'm going to pull up the slide deck really quickly just to formally close the session as usual. If we can just pull up the deck here, just a reminder to everyone that the sessions are recorded and we do have the links for them. And remember too that if you do watch the session afterwards and you didn't see it before, you can claim a main pro credit for it, but you need to do the self-learning thing that I talked about at the beginning of the session. Next slide. Just a reminder that we do have some upcoming sessions coming up soon, next one being June 6th. Next slide. Again, thank you everyone for attending today's session. If you can, please do fill out the evaluations. They're very important, and especially for things like for Tara's talk, where she stirred up lots of conversation and ideas. If you'd like to see more of that type of thing, maybe we have an opportunity to dive into this a little bit more, because I know we had limited time today. Let us know on the evaluation, because we look at those and that helps us plan the session, so they're best meeting your needs. And with that, I wish you all a wonderful weekend. Let's hope for some warmer weather, and we'll see you soon. Take care.